Beckmann, who is the chair of the Airway Special Interest Group for ANZCA, the ASA and the ASNZ. Can you hear me? Yep, okay. So we're trying to build a close partnership with the Airway SIG, and so we regularly invite Linda to present.
So look, thanks so much for having me along this morning. Aside from being the SIG chair, I have a clinical interest in head and neck anaesthesia. So I do a lot of airway lists, and I guess I enjoy the challenge and the complexity that goes with those kind of cases. I love it when people come to talk to me about patients and show me scans and nasendoscopy videos. And as part of that, I guess I'm always thinking about techniques and what other institutions are doing, as well as what's topical in the literature. So I wanted to speak today about two airway issues that I think should have broad appeal. So the new cervical spine guidelines, and also about steerable bougies. And at the end, just give a couple of quick updates on some ongoing projects of the Airway SIG, which I touched on last year, but I think is still relevant. So the Airway guidelines on management of patients with suspected or confirmed cervical spine injury were released online in May this year and appeared in the August edition of Anaesthesia. I've had the opportunity to hear Matthew Wiles, the lead author, speak to these guidelines on a couple of occasions. And it's certainly always good to hear firsthand and get some background insights into the work. The author list on the guidelines included anaesthetists, spine surgeons, emergency and pre-hospital physicians, and also intensivists, and represented consensus opinion from the UK Difficult Airway Society, their Emergency Medicine College, and also their Intensive Care Society. And I have to say, I guess sometimes when you read these big guidelines, at first glimpse, there doesn't seem to be any new news, but it's always good to really get into them and see what the experts think after immersing themselves in all the available evidence and really try and pull out the nuance. And sometimes that nuance, I guess, doesn't appear in bold, in the bold print, but it is there when you look. And so I thought some of that could provide some interesting discussion points for us today. So some things, such as the use of jaw thrust rather than chin lift and head tilt, and the clear evidence of superiority of using a video laryngoscope in terms both of success and reducing vertebral body movement are hopefully pretty straightforward and already well appreciated. Using the video scope to obtain a minimal glottic exposure view, I guess, as opposed to the best possible view, and using an adjunct such as a bougie or a stylet, with slight evidence that a bougie might be better, to reduce the need for external laryngeal manipulation was also recommended. And of course, they made note of the need to remove the anterior part of a hard collar prior to intubation. Using a supraglottic airway device, if you want to use one for airway reasons, is fine, but they shouldn't be used for the purpose of reducing head and neck injury. No supraglottic airway has proven to be superior for reducing neck movement, so the guidelines suggest using the second generation one that you're most familiar with. C-spine immobilization itself doesn't inhibit the effectiveness of an LMA in terms of ventilation. And then just touching on awake fibre optic, I've personally never understood why it's been recommended in the past for suspected C-spine injury, and the guidelines certainly address this. In addition to there being many practical reasons why an AFI might not be a good idea, such as a patient lying dead flat, they might be non-compliant from concomitant brain injury or alcohol intoxication. There's no evidence that an awake fibre optic is superior, meaning there's no evidence that compared to a laryngoscopy under a general anaesthetic, that it causes less cervical spine movement. There certainly may be other non-C-spine reasons to choose an AFI, but I guess that then becomes a case-by-case decision. Another point of interest was the guideline issuing a cautionary note about the use of high-flow nasal oxygen in multi-trauma due to the potential risk of evasive skull fracture. and that was based on at least one case report of a pneumocephalus. The article makes the point that many of the studies that looked at this issue have been done on cadavers, and they've created catastrophic injuries that, had they occurred, would have caused immediate death. And many of the studies have also looked at vertebral body movement using a lateral C-spine X-ray. And they make the point that the stack, or the space available for the spinal cord, is actually dynamic and three-dimensional. And it's that reduction of space that will actually cause spinal cord impingement. And the accuracy, I guess, of using lateral C-spine movements as a surrogate marker really isn't known. Quite good pressure. All right, a vexed topic, but applying anterior pressure, in particular with posterior neck support, does not seem to cause any significant movement at C5-6. If you're going to remove it at the first sniff of an airway problem, then I would think, why use it at all? That's my opinion. But the official recommendation is to use it if you're trained, and to remove it if the intubation is difficult. I touched earlier on using the recommendation to use a bougie to avoid external laryngeal manipulation, but the final recommendation is to use that manipulation cautiously if it helps you get a view enough to intubate, because without it, the intubator is more likely to pull harder and create more movement. As all of you know, probably better than me, manual inline stabilisation has copped a bit of a beating in the literature over the past few years. And some groups of clinicians have already stopped using it. It is still a recommendation in the ATLS and NICE guidelines. And from my straw polling, still preferably employed at least by the majority of DEM, ICU and anaesthetists in my hospital. Matt Wiles, the lead author on these guidelines and also the editor-in-chief of Anaesthesia, has previously published on manual inline stabilisation. And I really like his pragmatic approach to the topic. What we do know for sure is that Mills makes intubation harder, and there's very limited evidence to say that it reduces the risk of cervical cord injury. It may actually increase subluxation depending on the level of the injury. So I guess it gets put in the same basket as cricoid pressure, really. If you choose to use it, and then that's fine, but then removing it with the airway is difficult. But there's a bit of an overlay of why would you choose to use it in the first place, but that's not written down in as many words. I kind of reached out to an Airway SIG member, Marianne Balkin. She's an anaesthetist with an airway interest, but she's also trained as a lawyer, just to get another opinion on this topic. She pondered the issue for me, thinking about a potential negligence claim, say if Mills was omitted, and sent me through a very thorough response. And I guess the summary of that was she confirms the issue is grey, and that either side of the legal argument could be supported. The parting note in the discussion section mentioned that more research was needed as to whether a steerable or a flexible tip bougie as an adjunct to a hyperangulated VL could be useful. So this is how we'll gracefully move across into the next topic for discussion. So flexi-tip bougies, or STIGs, they're not new, but perhaps still underutilised. They have an incorporated slider which allows you to manipulate the tip. I guess as an anaesthetist, if we had problems intubating with a hyperangulated video laryngoscope, we'd likely preferentially use a VAFI technique, so have a second operator on a flexible bronchoscope. The obvious disadvantage is the need for that second human, and also the cost of the bronchoscope, which is several $100s. It seemed like a really good option to be able to have something more portable that a single operator could use and at a lower cost. So I had a look at the publications on this topic. Since 2019, there are just over a handful of articles, quite a few of them on mannequins, and all obviously unblinded. Some of the points that come through are that they are surprisingly cheaper than a standard bougie. There's less bougie impingement on the anterior tracheal wall when using a hyperangulated VL blade, and overall easier intubation. The ease of intubation was superior for both novice and experienced users, with a trend towards reduced time spent intubating, reduced at least mannequin dental compression, and increased first pass success. Certainly no one seemed to do worse with these devices. As there's reduced hang up on that anterior tracheal wall, it was suggested that it might cause less trauma and as a result of that, less sore throat. But the numbers were too small to prove that. Trauma does seem less likely, not only as you can steer the bougie tip away from the tracheal wall, but the tip itself is actually quite soft. The other advantage being that it's a technique that can be used in the presence of blood and secretions, those which may make a fibre optic tricky. So I've just got a short video of the device in use. This is a nice little study about a novel use for nasal intubations, I guess probably more applicable to the anaesthetist in the room. But it was 5 cases where in the setting of an anatomically difficult airway, where a nasal tube was planned for surgery, instead of performing an asleep fibre optics through the nose, they instead, when the patient was asleep, put a nasopharyngeal in the nose, then the video laryngoscope in the mouth, and then use the steerable bougie to intubate, and then at the end replace the nasopharyngeal for the nasal tube. I thought that was quite a nice little article. The skill itself seems easy to set up and practice on a mannequin. It doesn't require extensive training. And as mentioned, the tip of the device is nice and soft, and it's a bright yellow colour, which is good for visibility. Problems, I guess, only a few. The tip is quite flexible and it can fold back on itself. Also, because of the external ratchet on the device, it needs to be used with size tube 7 or larger. By comparison, a standard bougie can be used with a size 6 tube comfortably. And as with everything, you need to use it a couple of times and get a feel for it. However, the learning curve is really quite short. All right, so it wouldn't be a SIG talk if I didn't give a plug for some of our ongoing projects. As many of you have heard me already bang on about a few times, we've been working towards the standardisation of when and how a difficult airway alert is recorded in the medical notes. This all stemmed from the Queensland Difficult Airway Alert process, which started back in 2019. And the group sought broad consultation from anaesthetists in Queensland and airway experts through Australia and New Zealand. We set about to refine what was at the heart of an airway difficulty and streamline a document that was a balance between brevity but contained enough information to inform future care. We recognised that well-defined and uniform information that could be recorded in the medical record and disseminated was key. So the document was agonised over on every level: definitions, graphics, the amount of free text space. It's well supported by a background document, and that gives some guidance as to when an alert should be generated. We're certainly encouraging the uptake of this form as the standard. It's been endorsed by both ANZCA and the ASA. It's undergone some recent minor updates, and there is an editable PDF version that would be suitable for an electronic health record. I'm certainly not a digital health person, but if you have any questions about accessing this form for your own hospital's branding or a version that would be suitable for an electronic record, our project coordinator can help, and her email's on this slide. Certainly, while the majority of airways that are difficult outside of theatre are that way because of the clinical circumstance, and that clinical circumstance may not be present in a future encounter. But as I mentioned last year, if the difficulty is due to something that is unlikely to change, any airway practitioner can generate one of these alerts. I guess I also wanted to do a quick plug for airway leads. So the idea is to have an airway representative within every hospital. If you're unsure if your hospital has an airway lead, certainly the director of the anaesthetic department would have that information. Local airway leads at the hospitals are supported by a state lead who is a nominated member of the Airway SIG executive. So there is a network of support and collaboration. The role of the lead is broadly looking at education and training, implementing practice from best guidelines, addressing any safety gap between what's actually happening and what should be happening, looking at equipment, collaborating with all airway managers within a hospital. And one of the more important roles, I think, is looking after people after adverse airway events and looking at those cases in detail. I guess more importantly, I really see it as a person with the interest and enthusiasm, who's approachable and sensible and can kind of act as a go-to person within a hospital for all things airway related. So I do the role in my hospital, and rather than being prescriptive, it's quite sort of organic in nature. People come to me when we're short on equipment. We talk about equipment trials. We debrief after airway events, and I coordinate some case presentation within the anaesthetic department. And lastly, the Airway SIG itself is undertaking a process of general membership and executive membership renewal at the moment. We're also working with ANZCA, the ASA, and the NZSA. They're our three sort of overarching bodies about our overall mission and purpose. We're shortly appointing some new executive members after quite a few long-standing members have moved on. And I guess to be on that executive, you just need to be a member of the SIG and to apply. We're always keen to hear from keen airway managers, whether their angle is research or education or clinical expertise. We seek to have broad representation across the country and New Zealand. And I'll put my email address on the last slide if anyone has any further information, wants any further information. All right, that's all I had. I'm sorry I can't hear anything from the audience, but thank you very much for inviting me, and I hope you have a lovely meeting. Thank you.